Good afternoon, everybody. We're going to start the World Obesity Federation session, which I have the privilege to serve at the Clinical Care Committee, along with Carol LaRue and other sitting here in the audience. And we're going to have a slight change in the order of the presentations. I'd like to introduce the two panelists with me, Luca and Dimitrios. So we're going to start with the first presentation and then this discussion and questions in the end. So the first presenter is Lee Kaplan. He'll speak on the body fat set point theory when treating obesity as a disease. Kaplino, please.
Thank you very much, and thanks for inviting me. And I took the prerogative of taking the word theory out of my talk title and changing it a little bit. So I'm going to talk about metabolic adaptation and defense of body fat mass and their implications for obesity therapy. Here are my disclosures. They don't directly relate to the talk I'm giving. Now, there are two competing models for fat mass regulation. One is that our purposeful behavior drives the physiology, and that has implications. It would suggest that increased consumption of calories is what drives weight gain, and that all types of calories, therefore, have somewhat similar effects based on the amount of energy that they contain, and that physical activity causes weight loss directly by burning calories. Now, that works, and I will argue that that is true in the short term, but it doesn't work in the long term, which is why we have the other model, which is that there's physiological regulation of body fat mass that drives our behavior. And that our behavior is not entirely voluntary, but that it responds to cues in the environment, but it also responds to internal cues to allow the body to seek and maintain the right amount of fat. And the implications for this model are that what's causing obesity in the modern environment with relationship to food is the chemical content of the food that influences the brain regulation of this process. And that if we want to fix obesity, we need to re-regulate that process. And we're not going to be able to do it simply by voluntarily exercising more or eating less. So here's a study that was done many years ago by Steve Woods and colleagues at the University of Washington. And what it shows is that three groups of animals. These are animals, and I'll emphasize where they're animal studies and where they're human studies, but these are animals. And you'll notice that in the middle, the group of animals shown in black are rats that were allowed for a quarter of their lifespan. So for a quarter, the equivalent of 20 human years, were allowed to eat what they wanted, which was, and you can see that they gained weight from about 250 grams to about 310 grams. And that is normal. That's healthy diet. That's a normal weighing rat. A second group of animals was given a gastric tube and overfed by 15%. And that 15% caused them to gain weight. And they continued until the green arrow to be overfed. You'll notice that they stopped gaining weight during the period of time that they were overfed. But they were overfed all the way to the green arrow. And then the third group of animals was underfed by 15% by limiting the amount of food in their cage. And so they lost weight, and they lost weight until, again, to the green arrow, or they were underfed until the green arrow, but they only lost weight for part of the time, and then they stopped losing weight, even though they were underfed. They continued to be underfed. And what you see after the animals got to the green part is that they were allowed to eat whatever they wanted. So the animals that were overfed and were overweight ate less until they got back exactly to where they would have been. They didn't stay overweight. They didn't go back to where they were. They knew exactly for their age and point in time in life where they should have been. Having never been normal the whole time they were there, they had never been at the normal curve, and yet they went back to the normal curve. And the animals that were underfed went they were 90% of the weight, 97% rather, of the weight that they would have been had they been on the black curve. And we think that the reason that they're under that by 3% is they lost muscle mass on the process of losing weight, of losing body fat mass. But once again, they knew exactly where they should have been at that time, a quarter of a lifetime later, and they went to it very quickly, as you see here in this slide. So how does that work? How does the body do that? And does it relate to humans, or is this just a unique thing for rodents? So if this is true, then there must be programs driven by the central nervous system to establish what the fat mass is supposed to be at any given time. To tell a woman when she becomes pregnant she's supposed to gain fat. To tell a baby that they're supposed to lose fat, baby fat. To tell a girl who's going through puberty that she's supposed to gain fat. And so there must be a program to establish that target fat mass, and there must be a way to defend it, because if you get sick with COVID or the flu or something and you lose weight, the first thing you'll do when you recover is to regain the lost weight, because the body defends where it wants to be at that point in life, at where they should have been before they got acutely ill. So obesity then, under this model, develops because of disruption, not of the second program, but of the first program. The setting of the target fat mass is disrupted, and that leads to obesity. It could also lead to other problems, but it leads to obesity because that's the most common disruption of this. And so in all common forms of obesity, the defense of the target fat mass is intact. This has important implications for how we think about obesity, because if the opposite were true, you would get things like mindless eating leading to obesity, because you would get you would no longer have a defensive fat mass, and you would just start eating because you got distracted, and since your body doesn't defend anymore. But that's not the way it works. Your body does defend, and I'm going to show evidence for that in a moment. So your body defends its fat mass to where it wants to be, and in obesity, it wants to be in the wrong place, which, by the way, it's not in the slides, is why obesity is a disease. Obesity is not a disease because it causes diabetes. Obesity is not a disease because it causes cancer. Obesity is not even a disease because it causes other diseases that kill you. It's a disease because this system is not working correctly, which is the definition of a disease. So let's look at what happens after you go have a calorie-restricted diet. The first thing that happens is what's called phase 1, which is the acute weight loss. This is a very low-calorie diet-induced weight loss. You see substantial weight loss, this is a 100-kilogram person, so this is about an 8.5% weight loss over the period of 6 months. And then what happens as the person is trying to maintain that weight is no matter how they try, they end up gaining back within a year about half of the lost weight. In other studies, as I'll show you, they gain back a lot more than half of the lost weight in a year. This is what's called weight maintenance, but it's not weight maintenance, as I'll show you, it's something else. I won't tell you exactly what I'll call that in just a minute, but it's not weight maintenance. No matter how hard people try, it's not weight maintenance. It is phase 2 of this process. And this phase 2 is why it doesn't work. So people say, well, weight maintenance is the hard part of obesity care if you're trying to do self-care in obesity, because it's easy to lose weight, it's hard to maintain it. It's also easy to hold your breath for 20 seconds, but it's very hard to maintain the breath hold for another 2 minutes or even 20 minutes. Because the initial effect of holding your breath changes your physiology, so it forces you to breathe. The initial effect of losing weight by this method is such that it will force you to regain the weight no matter how hard you try. Some people have a lot of willpower and can hold their breath for 3 minutes. Other people have less willpower and can hold their breath for only 20 seconds, but everybody will breathe unless you have a Pontine stroke. So the defense of body fat mass occurs, and it occurs in both directions. And so just to give you a sort of a summary of where we're going, if you have intentional weight gain, if you try to gain weight, some kids, sometimes their parents want them to be heavier, they try to make them gain weight, is met with a counter-regulatory process that pushes it down. And if you try to lose weight, that's met with a counter-regulatory process that tries to push it back up again. And that counter-regulatory process is what accounts for that weight gain that I just showed you a minute ago. So, as I mentioned, what's wrong in obesity is that the body chooses to set the wrong amount of fat, and that's shown here by the horizontal black line. But in obesity or in normal weight people, If you're above where your body wants to be, you will have what I call the hyperadiposity state, more fat than the body wants, and the response is that you will lose your appetite and you'll increase thermogenesis. Not physical activity, thermogenesis. And if you're under where your body wants to be, the opposite will occur. I call that the hypoadiposity state. And the response to that is to increase appetite, to increase all aspects of appetite, which means increase hunger, decrease satiation, decrease satiety, increase craving, do all the things. The whole body is, the whole brain is set up in multiple parts to respond by increasing appetitive drive and decreasing thermogenesis or conserve energy. And that will push you back up. So what is hypoadiposity? Hypoadiposity is the state of having less fat than the body's target amount. So if your body wants to be here and you're here, it wants to gain that fat back. It's not weight loss, because weight loss isn't the only way you can get there. If you take a drug that makes you want to gain weight, then during the period of time that you're gaining weight, your body is hypoadipose. It's not diminished body fat, because in hypoadiposity, when you take a drug that makes you gain weight, or put yourself in an environment that makes you gain weight, you actually have more body fat, but you're still hypoadipose. It's the relationship between where your body is and where it wants to be, and it can occur in people of all sizes. It's similar to what's been called the weight-reduced state, if you've heard that terminology, but it's not always weight-reduced. And not all forms of weight reduction lead to it, which is a critical reason why we don't call it that, or why I don't call it that. Hypoadiposity does not have to have resulted from weight loss, and weight loss doesn't have to result in hypoadiposity. So here's an experiment done now 28 years ago by the group at Columbia University in New York, led by Rudy Leibel and Michael Rosenbaum. And what they did with people, we've moved from the rats to the people, is that everybody was at their initial weight. Some of the people had obesity, and some of the people were normal weight. There was no difference in response between the people with obesity and the people with normal weight. That's how we know that the defense of body fat mass is maintained normally, even in the setting of obesity, because this study looked at people with obesity. And they took a group of people and they overfed them. They say, eat more, eat more, eat more, and gain 10% of your weight. And that's what they did. And then they allowed those people to float back, at the end of the study, to float back to normal. Then they took the same people and they said, okay, now eat less. Same food. They're going to eat the exact same food. They didn't change their food. They just ate less of it. It was a prepackaged meal. And they lost 10% of their weight. And then they said, now when that was done, if they hadn't been through enough by then, they said, now the last part is you're going to lose another 10%. So you have a period of time when they were forced to be overfed and forced to be underfed and then forced to be more underfed. And by the way, I'll just tell you parenthetically, the people in the study, some of them stayed in these chambers where they had their energy expenditure and their appetite and their food measured for as long as 9 months. So you figure, who would do that? Well, poor graduate students, medical students who weren't really going to medical school, but mostly authors. So authors could do their work, so they lived there for 9 months in this nice little box. But the question was, what did they learn from this study? And so they did energy expenditure studies, energy intake, neuroendocrine axes markers, and autonomic physiology, muscle physiology, and brain imaging. And I'm only going to show you one or two of the studies, but they did all of these studies. They're all published in the New England Journal and elsewhere, so you can see them. So the physiology of the weight-altered state, hyperadiposity, was done initially. They were forced to overeat. So this was baseline. If you'll notice that the fat-free mass is associated with the amount of energy that you burn. This is that relationship shown here on this solid line is the relationship that we all know about, that the bigger you are, the more muscle you have, the more fat-free mass you have, the more energy your body's going to burn by total energy expenditure, and most of the difference is due to changes in thermogenesis. After these people have been encouraged to eat so much that they gain 10% of their weight, this is what happened to their total energy expenditure. It looks subtle, but it's significant that their energy expenditure went up in response to overeating and gaining body fat mass. They didn't gain body muscle mass. This is a body fat mass that they gained, and they increased their energy expenditure, which would tend to reduce their weight. In hypoadiposity, later in the study, what happened was these people were still a little bit high. That's why I told you the details of the study. They were still a little bit above the line because these were the same people that had been hyperadipose. And then they were encouraged to lose 10% of their weight and then 20% of their weight. You notice there's no difference between 10 and 20%. But they suddenly fell below the line. As they lost weight, they no longer were hyper in terms of their energy expenditure or thermogenesis. They were hypothermic. They were hypothermogenic. So you can see here that the body responded very quickly and very powerfully. These are not subtle differences when you add them up day after day after day. So if you look at it, the summary of all of this work was that you have people who were normal in the study, people who had obesity in the study, and of course, if you were going to go up this line, because people with obesity did have more baseline energy expenditure because they were bigger people, they had more fat. Fat does have some degree of metabolic activity. If you go up the line, okay, then you are being appropriate for your size. If you go down the line, you're fixing your obesity, if you have obesity. But what happened was with the overfeeding, they didn't go up that line. They had more energy expenditure than they should have had for all the weight that they gained. And when they were underfed, they had less energy expenditure than they should have had for their size. And these are just summaries of what it was. And so underfeeding, of course, is calorie restriction, and overfeeding is calorie excess. So physiological weight loss would keep you on the curve. But because this weight loss induced some kind of reactive process, it took you off of that curve that should relate you to the size of your body and make you burn fewer calories in response. And burning fewer calories means you're going to gain weight. And so when you summarize all that, what you have here is on the curve that looks black to me, I think it's green, anyway, it looks black to me, is the appetitive drive curve, and the curve that's red is the thermogenesis curve. And as you move to the left, meaning that you lose weight by restricting your food intake, your appetitive drives go up, your thermogenesis goes down, you put yourself in positive energy balance until you regain the lost weight, which is exactly what you want to do after you've recovered from COVID, or the flu, or some operation. On the other side, if you overeat, you'll put yourself in negative energy balance by increasing thermogenesis and decreasing appetite. So much so, as I said, that was the worst phase of the study for most patients. And so the process of doing that is called metabolic adaptation, and metabolic adaptation in people includes appetite adaptation as well as thermogenic adaptation. And of course, it works in both directions. So you can have metabolic adaptation that pushes you back to the center there, to that gray bar. That gray bar, of course, is the so-called set point or defended fat mass. And the further you are from that gray bar, the more powerful it is, particularly in the direction of increasing thermogenesis. So here's an example of that. This is The Biggest Loser. It was a TV program that was very popular in the United States about a decade ago. And patients, or people, not patients, people who were on the show, contestants, like this young lady here, were encouraged to exercise a lot. But the reason that they were encouraged to exercise a lot, they were really given a very low-calorie diet. But they were encouraged to exercise because, can you imagine watching a television program where all you do is watch people not eat? That wouldn't be that much fun. So they made them exercise and sweat and scream and yell and everything else. And they became thin. And she became thin just like everybody else. Everybody became thin. The person who became the thinnest won, got lots of prizes. Most of the prizes were trips where you could go on a resort and then eat a lot of food. And that's exactly what they did. So what you see here is this is the weight curve that they have, and that when they were low because they had eaten less, their physiological drives that I just told you about pushed them back up again. And a study that was done by Kevin Hall at the NIH 6 years later showed that people had mostly regained all the lost weight. And if they hadn't regained all the lost weight, they were still too low on thermogenesis. and their hunger was still too high. But most people had regained all the lost weight or more. Now, the opposite also is true. If you look at Robert De Niro playing the aging boxer in Raging Bull, this is a 40-year-old movie. What you see here is what he looked like at the beginning of the movie, and a few months later, this is what he looked like in the middle to the end of the movie. He had gained 40 pounds, 20 kilograms. And so he purposely overate, and what he did was, again, the physiological force was to push down. He decreased his appetite, he increased his energy expenditure through thermogenesis, and 6 weeks after stopping the filming, whoops, you see the picture? Whoops, I'm going the wrong direction here. Can we go the other way? Yes. 6 weeks after finished filming, he was within 5 pounds of his baseline weight without trying. His body wanted to lose the weight. And so you see that here. So how does the body do this? How does the body defend its fat mass so that after the very low-calorie diet that I showed you, and this is a study by Sumitran and Proieto and colleagues in Australia, what they did was they did the same study that I showed you before. You go on a very low-calorie diet, and then you try to maintain that. And what happens is they looked in this study, they did more science than just watching it. They looked at week 0, week 10 after the acute weight loss, and at week 62 after a year of trying to maintain it. And they looked at various parameters, and they first looked at hunger. And on the right, it's a different curve. The right is a 4-hour curve. The left is a 1-year curve. The right is a 4-hour curve, and you're looking at before a meal, that's time 0, and then right after the meal. And you see that in the blue line, that after these people have lost weight, they're hungrier than normal at every point. And after the red line, when they've regained only half their lost weight, they're still above. Their hunger is still high. And you say, well, it's not hunger. This is about hedonics and the hedonic drive, the craving drive. Well, they looked at that too, and they found the same thing. So craving is elevated as well after you lose weight by restriction. And so then they looked at various hormones like ghrelin. You all know ghrelin because ghrelin stimulates hunger. And you see that at every point before and after a meal, the ghrelin levels were elevated, not only right after they lost all the weight, but a year later when they were still below where they should have been. And then they looked at a hormone PYY, which is a satiety hormone, and the opposite was true. Satiety was decreased. And then they looked at a few others, amylin and CCK that you know about, and they were decreased too, at all points before and after a meal, at all points in the journey when they first lost the weight and when they were a year later had regained only half of the weight. So to summarize then, the story here is that there's physiological weight loss that I'm going to show you includes targeted lifestyle change, changing the environment that's causing the obesity in the first place. If you have obesity because you're sleep deprived, or you're jet lagged all the time, or you're stressed all the time, or you eat an unhealthy, like a highly processed food diet, then you could fix that. If you happen to be the person who has that as your primary cause of obesity, you can fix that by reversing that environment. Effective medications and bariatric surgery also are physiological ways of losing weight. And so what happens is you start the treatment, whatever the physiological one, and it lowers your defended fat mass. That's how the treatment works. That's how bariatric surgery works. And that's almost all bariatric surgery. There are a couple of exceptions. But all the ones you use today work this way. And that's how good drugs work. And so because you've lowered the defended fat mass, the body chases that by lowering appetite and increasing energy expenditure until it gets there. Now notice, it's where it wants to be at the end, right here in the curve. And because it's where it wants to be, it stays there. And that's why you have relatively less weight regain after drugs or bariatric surgery. Bariatric surgery, average weight regain over 10 years is about 25%. Calorie restriction, average weight regain over 10 years is 80%. So just the difference between 25 and 80% is the difference between physiological and non-physiological. Now, what happens when you take away the therapy? So here you have the therapy, it's physiological, and then over time you just take it away. You stop the drug or you stop the surgery by reversing, say, a gastric bypass. what's going to happen is the defended fat mass is immediately going to go back up again because you've taken away the thing that keeps it down. And so when that goes up, it gets chased again with increased appetite, decreased energy expenditure, until the body goes back to where it started. That's the reason why you regain the weight when you reverse a gastric bypass even 25 years later. So, now let's talk about the last thing I want to talk about, because you're going to hear for the other two talks about what happens in terms of energy balance and in terms of effectiveness of drugs and bariatric surgery mechanistically. So I want to show you one study that was just published about 3 years ago now. This is in rats again, we're back to rats. And in this study, animals were either treated with semaglutide to lose weight, or they were forced to lose weight by calorie restriction, which you can do because the animal's in a cage, or they were given the equivalent of placebo. We call it vehicle, but it's placebo. And you'll notice that the placebo-treated animals in gray on the left gained a little bit of weight, and the animals that got semaglutide lost weight, and the animals that were calorie restricted were forced to lose weight by virtue of the fact that they were supposed to, by design, they were going to follow the same curve. And if you look at what happens to energy expenditure, there's the dark phase when they're eating and the light phase when they're sleeping most of the time. You'll notice, particularly in the light phase, that what happens when they restrict their food intake, in the black line, they decrease their energy expenditure. I just spent the whole talk emphasizing that. But when they get semaglutide to do the same job, they don't decrease their energy expenditure. And the lesson from this study, and it's been repeated with tirzepatide, it's been repeated with bariatric surgery, the lesson from this study is that all of these effects that try to reverse the loss of body fat are blunted when you have a physiological means of weight loss, in this case semaglutide, but also true for all the operations that most of the surgeons in this room do. And that's why surgery works, and that's why it works so well, and that's why it works so long. But remember that the surgery is always working, even to the end of the patient's life. And in those operations that you can reverse, the first thing that will happen is, if you reverse them at any time in the patient's life, is they're going to regain all the lost weight if they've kept the weight off that whole time. So, in conclusion, hypoadiposity is the physiological state of the body having less fat than it currently wants. It generates these counter-regulatory forces that we call metabolic adaptation. They influence not just energy expenditure, they also influence the appetitive drives, because it's a balance between the two. They work in both directions. Whether you lose weight by calories or you gain weight by calories, you will get that reversed. They account for the limited effectiveness of non-physiological weight loss strategies. They also account, by blunting them, for the effectiveness of effective physiologically based strategies, including bariatric surgery and the newer and the older medications when they work, but particularly the newer medications because they work so well. So clinical evidence, decreased appetite, durability of response suggests that physiologically mediated lifestyle changes similarly reduce weight without inducing hypoadiposity. There are situations in some patients where you can see dramatic weight loss because of physiology if you've hit upon the reason that they had obesity in the first place. Calorie restriction is not the way to do that, however. Thank you very much. And I'll just leave the implications up here. If we can put the implications up as I give it over to, could you put that last slide on, please? I guess I can't. Okay.
Maybe we can talk about that during the discussion. So we will move to the second speaker. The second speaker is Carol Leroux. I don't think that Carol deserves so much presentation. She is currently working in Ireland, in Dublin, and the title of the talk will be Mechanism of Drug.
Well, thank you very much for the introduction, and I'm going to build on what Leah said. If I can have the next set of slides, please. So so first of all, the most important thing you need to know about medications is that they will not make your patients more intelligent, and they will not make your patients more motivated. They will do everything that Leah said. They will work through physiology. So this is Dante's Inferno, depicted by Botticelli, where the two mortal sins, gluttony and sloth, are pushed out. And of course, this is important, that our patients will not become better citizens because we are treating them with medications. We are genuinely treating the biology of this disease. These are my conflicts of interest. And on the right, we are showing Sisyphus, our Greek character that's pushing this rock up this hill. And that's exactly metabolic adaptation that Lee has referred to. The eat less, move more strategy that has not served us very well when we treat the disease of obesity. So just be careful when you give somebody a biological treatment such as bariatric surgery, or you give them a biological treatment such as medication, that you don't also ask them to eat less and move more. These treatments do not make eat less, move more work better. They work in a completely different biological way. I'm showing Ricardo Cohen's slide that you may have not seen before. This is Ricardo's MOMS study depicted in the orange at the bottom. This is the amount of weight loss that people lost after gastric bypass surgery in Ricardo's center. And in the top, I'm showing you the evidence of one of Lee's studies that just published on retadratide. And you will see the amount of weight loss after 48 weeks is very similar after medications and after surgery. Surgery is outperforming a little bit, but you can see certainly top dose of retadratide is overlapping with the amount of weight loss. And that is very important, because we now understand that the way medications work is almost identical to the way that surgery works. And if you are able to combine those, you'll see very similar outcomes ultimately in the end. Now, for us to understand the mechanisms of medications, but as well as the mechanisms of surgery when it comes to treating the disease of obesity, we need to identify what organ is it that we are treating. Because for a very long time, we thought our target was that we needed to treat the organ of adipocytes, adipocyte mass. But in fact, as Leas explained, adipocyte mass is regulated not by the adipocyte. It is regulated probably by higher centers, and this gene-wide association study would suggest that at least 80% of the genes that's involved may be in the central nervous system. And if we dive into the central nervous system, it appears that it is the subcortical areas of the brain. I'm highlighting the hypothalamus, but also the area postrema, the nucleus tractus solitarius. And suddenly, it helps us because the mechanisms of the surgery that you are doing, or the mechanisms of the medication that you are doing, is actually treating the disease of obesity in the organ that is responsible for it. And that is the brain in about 80% of cases, and certainly the subcortical areas of the brain. Because when we give effective nutritional therapies, effective pharmacotherapies, or effective surgical therapies, we hear the same narrative from patients during the weight loss phase. And Lee was very clear about pulling those two phases apart. We're talking about the weight loss phase as that phase 1, but also phase 2, which is different. But for this moment, we're focusing on phase 1, meaning that if you give somebody an effective nutritional therapy for the disease of obesity, or you give them an effective pharmacotherapy or surgical therapies, the patients come back and they say, I feel less hungry and I feel more satisfied, because we are changing what happens in the arcuate nucleus, and ultimately we are changing appetitive behavior. So this is taken again from Lee's previous talks. This is an idea that what medications are not doing is they are not changing energy in and energy out. What medications are doing is exactly the same thing what bariatric surgery is doing, is it's resetting the amount of adipocytes that the body wants to carry. Now imagine my house you know, in Ireland where it's always cold. You know, I turn my house up to 25 Celsius, not by changing the windows and the boiler, but actually changing the thermostat in my house. I am deciding at what temperature my house will be. And when I turn my house up to 25 Celsius, the boiler will work very hard, and that's effectively, that's at least hypoadiposity state. So therefore, the system is pushing more energy in to get to the level where it wants to be. And at 25 Celsius, the house is in balance. But if I now turn the thermostat down, and I now go to 20 Celsius, what will happen is suddenly the boiler will not work. The boiler will switch off. And it will naturally allow the house to come down to 20 Celsius. And when it hits 20 Celsius, the boiler will start working again. And that, what the boiler is doing at that point where it's working again, that is the sort of the phase 2 that I would like us to spend a moment thinking about. Because that's probably the one thing that's caused me the most difficulty in understanding over the last 10 and 20 years when I've worked with patients after bariatric surgery and now with medication. What happens at that point where the body gets to the new balanced position, to the position where the body wants to be? You've already heard from Lee around the biggest loser, and we're going to just remind you that this is not what medication is doing. So what the biggest loser did is what we call a weight loss treatment. And a weight loss treatment is fundamentally different to an obesity treatment. So when you do bariatric surgery, it's not a weight loss treatment. You are treating the disease of obesity. When you give somebody a pharmacotherapy that they respond to, that's not a weight loss treatment, that is an obesity treatment. But let's see what happens with a weight loss treatment. Of course you can make somebody lose weight, but you change the metabolic rate, you change the metabolic adaptation. And what you are doing with a weight loss treatment is you're taking somebody with a disease of obesity, you're turning them into a hypoadiposity state, and in the hypoadiposity state, the patient is not in balance. They may have the amount of adipocytes that you want, but the patient is not in physiological balance because you've created an energy gap. There's increased hunger, there's reduction in energy expenditure, and those are the markers, the surrogate markers that we use to analyze it. This is what you should not do. This is metabolically unhelpful to you, to the patient, and certainly to society. So let's frame that in another way, and this is again building on what Lee said. So we know that the body fat set point can increase because of the poor environmental environments, for example, poor diet, not enough eating, or not enough sleeping rather, stress, etc. And we know that we can reduce the set point with good nutritional therapies, not calorie restriction, but here we are talking about healthy diet, better exercise, reduction in stress. These are true lifestyle treatments. These are therapies for the disease of obesity. It is fair to say that most people don't have a massive response to this, but there are some people that do lose a quarter of their body weight. There's a small number of them, but when it works, you know it works because the patients say, since I've started this lifestyle treatment, I'm not feeling hungry, I'm feeling full, it is really easy. That's when you know it's working. We now know we can be much better with medications. And what we see with medications is that the body wants to be 15, 20, or 25% less heavy because of the reduction in adipocyte mass. And we also know that surgery is still one of the best treatments that we have when it comes to treating the disease of obesity and patients wanting to be at a different set point. So I'm going to show some data. I know there's some of the authors of this study, really brilliant study, the Step 5 study. I think Rachel is in the audience and others as well, with semaglutide 2.4 milligrams for 104 weeks. And what you will first see on the left-hand side is the phase 1, is the weight loss phase. That lasted for about 64 weeks. And then you see phase 2, where patients were continued on the medication and their weight is now at the new homeostatic point. This is where their body wants them to be. And you can see that they are in this homeostatic point. But now let's go back to your clinic and my clinic and listen to what the patients are saying, and that's depicted on the right-hand side. So now we are asking patients about, how do they feel about, craving control, for example, and craving for sweets right at the bottom. So what you would see in the first 20 weeks, in the steepest part of that curve, when your treatment for the disease of obesity is effective and the body really wants to get down. So here the body, when the minute you start the treatment, the body thinks it's 16%, in this case, too heavy. So it wants to get down to the new level where it wants to be. The body has very few levers it can pull. One of the levers is to make you feel more satisfied. The second is to make you feel less hungry. And that's exactly what happens en route in phase 1 when you're treating the disease of obesity. And you can see that certainly at week 20 and week 52. Now you are seeing that there is changes in what patients are experiencing. And just maybe focus on the bottom, the craving for sweet foods. You can see how improved it is at 20 weeks. You can see how improved it is at 52 weeks. But then when the patient has been at that homeostatic point now for 104 weeks, you can see they just become normal. So now the cravings for sweet food is no different to what it was when they were 16% heavier. Because that is what is supposed to be. That is how what you have heard and I have heard for more than a decade after surgery, and I could not understand it. Patients came 1-2 years after surgery and said, "Doctor, this operation isn't working anymore." And you say, "Why?" And they say, "Well, I'm eating more, I'm not feeling full anymore, I'm feeling hungry, I'm thinking more about food." And then you ask them, "But what has happened to your weight?" And they say, "No, my weight is perfect. I have 25% weight loss, not changing my weight has not changed. But yet, I'm feeling more hungry, I'm eating more food," because that is what physiologically is supposed to happen. Just to emphasize that, this is again the step 5 study with semaglutide. What you can see at 104 weeks when it comes to the hunger ratings as well as the difficulty in resisting craving ratings, there's no difference between the placebo group and the treatment group despite 16% weight loss. That is very reassuring to patients, because what you can say to patients is that these are true treatment for the disease of obesity. And we are not going to make you eat through a straw for the rest of your life or eat rabbit food that you don't like for the rest of your life. What we are going to do is we're going to treat this disease. It's going to come under control. And yes, we do want you to have a healthy diet. We do want you to have healthy exercise, because healthy diet and healthy exercise will make you healthier. But it's not going to change your body weight when it comes to those specific interventions. So let's just remind ourselves, this is data after the Second World War from the Minnesota men's study, when patients were put on a calorie-restrictive diet to really understand how the Marshall Plan will work and how we need to refeed Europe. And at the time, healthy volunteers were starved over a 24-week period, and you can see the amount of fat mass that they lost, but also the amount of fat-free mass. And when patients were given ad libitum food, what happened is they regained the fat mass, of course, faster, and they remained hyperphagic until the fat-free mass came into balance. Again, coming back to the homeostasis that we need to achieve. Now, this is what's going to happen if you stop the medication. Because you can take the medication, which is a really good obesity treatment, and you can turn that into a weight loss treatment by stopping the treatment. So if you stop the treatment, the patient will be under the impression that they are 15% or 20% too heavy, and they will just go back up. And that is why it's important that we get the narrative correct when we speak to patients. These medications do not reduce hunger. These medications do not increase satiety. These medications treat the disease of obesity, and once your disease is controlled, you will be normal again. That phase 1 is an abnormal event, but it is short-lasting, maybe only a year, But when patients come to the new set point, then they will be able to eat more food, they will be able to get on with their lives, and yes, then it's also an opportunity for us to make them healthier by better nutrition and better exercise. But the goal is health gain, not weight loss. So ultimately, I'm going to conclude and say, what is the framework for obesity management? And I want to congratulate Obesity Canada, for really saying that the pillars, that, the roof is good nutritional therapy, good physical activity. That is what we need to do. But we need to underpin this with obesity treatments. And that could either be psychological interventions, pharmacological interventions, or surgical interventions. And these are in support of each other to hold up the roof of what we are trying to achieve. So in conclusion, anti-obesity medications treat a complex and chronic set of diseases of obesity. It reduces excess adipose tissue and improves health. But chronic treatment is required for a chronic disease. Thank you very much.
Thank you, Carl. We'll stay on the island of Ireland with Professor Muris from Northern Ireland, who's going to talk to us about the mechanism of action of surgery. Alex.
Hi. Thank you, Dimitri, and thank you very much for you in the audience. So let's start.
Yeah.
So these are my disclosures. Okay, this is not working very well. So if someone gives you a lot of money to study the mechanisms of surgery on diabetes, you say yes when they give you the money. If someone tells you to study the effects of surgery on body weight, you refuse to take the money politely. The reason is that it is very easy to study mechanisms of action on glucose and insulin, because you can take the blood sample, you can put it in the machine, and you get a good answer. If you want to study body weight, that automatically means you have to study food intake, you have to study energy expenditure, you have to study food preferences. How on earth are you going to do that? Are you going to ask people how much they eat and how much they exercise? Feel free, but the paper that you get the answer on is not worth anything. So this is why I'm saying that it is extremely difficult to study the mechanisms of action of surgery on body weight regulation, because we do not have gold standard measurements when it comes to measuring food intake and, to a certain degree, energy expenditure. In fact, if you do a review of the mechanisms of action of surgery on humans and on animals, you would want to pull your hair out, because there are very significant differences between what the human literature shows and what the animal literature shows. So what I'll try and do today is I will try to summarize the key findings that I think we can believe, and give you also an assessment and understanding of the uncertainties. And there are many uncertainties, even after studying surgery for about 60 years or so. So I'm going to be talking, let me go back, I'm going to be talking about the bypass mostly, because this is where most of the work has been done. I'll be talking a little bit about the band and to a certain degree about the sleeve gastrectomy. I'm not going to be talking about other procedures, because there will certainly not be enough time, but I will give you the basic principles. And the first basic principle is that none of these operations that you can see on the screen cause mechanical restriction to food intake. No mechanical restriction. The flow of food in the bypass model, in the sleeve gastrectomy model, is either is probably faster than in the normal pre-surgical state. And that's why in the guidelines that we wrote for IFSO as a group, we stop calling these procedures restrictive, and we stop calling these procedures malabsorptive. So may I ask you to carry on doing that, because then we are using the same correct language between ourselves and between us and our patients. No restriction. When it comes to malabsorption, and I'm moving on to the slides here, there is minimal fat malabsorption after the gastric bypass operation. It has not been measured in humans, as far as I am aware, and not in an appropriate manner after the sleeve gastrectomy or the gastric banding. But of course, I would be very surprised if there is any calorie malabsorption after these procedures. There is certainly caloric malabsorption after other operations, like the biliopancreatic diversion or the duodenal switch. And these contribute to weight loss, but to a certain degree, this is unphysiological and not necessarily what we want to achieve. So, what effect does surgery have on the levers that Carl was talking about, which is hunger, fullness, and food intake? Again, I'm stressing, I'm mostly concentrating on human data. So when you ask humans relatively soon after surgery how they feel in terms of their food intake, how they feel in terms of hunger and fullness before a meal, they will tell you that before the bypass they were more hungry, after the bypass they are less hungry, and they are more full. Now, you're going to tell me that if they say that, first of all, it's true, and secondly, it means that they eat less. And I'm challenging you and say, well, prove it then. Prove that these people eat less after these operations, and prove how much they eat at each stage after the operations. So these are very, very, very difficult experiments to do in humans because they do not live in a cage. So that's why I contributed to as part of a bigger grant between Ireland and the United States was to study people before and after surgery, after gastric bypass surgery, in a residential environment. We invited those people and they stayed in an experimental medicine unit for 36 hours. And what we tried to do is to measure their food intake in as normal kind of an environment and circumstances as we could. We also had controls, and we did these measurements before and up to now, doing them 5 years after surgery. I will be showing you some of the results that are currently available and have been published. And these are the main results. These are how much people eat during 24 hours. And you're starting to see a number of things. You're starting to see that, first of all, the food intake that the people have, this is in megajoules, the food intake that people have before surgery is approximately 5,000 calories per day, which is much closer to what we would expect based on energy expenditure measurements, and very far from what we get when we ask people how much they eat using food diaries. What you will also see is that, yes, food intake after surgery in blue goes down. And in the first 3 months after surgery, surprisingly, people will eat about 2,500 calories a day. If you asked me how much I thought people ate 3 months after surgery, I would say 1,000 calories, maybe a little bit more. So 2,500 calories a day. And you are telling me this procedure causes restriction, right? It doesn't. So what you will see that after 12 months and after 24 months is that people still eat less after surgery, but they eat more compared to 3 months. And the reason why this happens is because they are gradually reaching their physiological state, they are gradually reaching the renewed set point, and as Carl just said, their feelings of hunger and their feelings of low satiety come back And here we're showing that this is indeed associated with increasing food intake. So this is as gold standard, I think, as it gets with these measurements. So based on these calculations that we've done between when we asked people what they ate and what we measured, we saw that even in healthy controls, people who do not live with the disease of obesity, there is a very large discrepancy. So we're looking at 20 to 30% difference between what people tell you and what people do. The second question is something that we observed some years ago, and we have spent the 12 years studying, is do people eat less? That's fine, but do they also change what they eat? Do they eat more healthily? Okay? Because what we saw after the gastric bypass, but we didn't necessarily saw after the gastric band, is that people reduce the amount of fat, reduce the amount of sugar as a proportion of the daily intake, and they change that into healthier food choices that include higher protein, vegetables, and fruit. And we spend a lot of time and we spend a lot of money trying to observe this effect in humans and rodents over the years. But when we actually do it properly, in the same setting that I have just described to you, in the same experiment, in the residential facility where we studied bypass patients, what you're going to see is that the proportion of macronutrients to their daily food intake does not change. So that might sound a little bit disappointing, especially for some of us that have been studying it for a while. But a caveat there is that there are some people, because here we're looking at means, there are some people that do change their food preferences. Certainly after the bypass, less so after the sleeve, probably not after the band. And we are speculating, this is pure speculation, that those people who do change their food preferences in addition to eating less are those people who lose even more weight than the average person. But the changes in food choices are probably not as critical as we thought 12 years ago. In the similar manner, dietary energy density does not change. Energy expenditure, that is a very, very difficult one. Again, not easy to measure. The best measurements are with these calorimetry chambers, the metabolic chambers that, again, you have to admit people in. Not the easiest experiments to do. There was some initial enthusiasm that after the gastric bypass, possibly after the sleeve, there is either an increase in energy expenditure or a stability of an energy expenditure in the context of weight loss. And there are people who have contributed to this data in the audience, and they might disagree with what I say, but it's important to go through the data in humans and then say that in this cross-sectional study, it appears that diet-induced energy expenditure is higher after the gastric bypass compared to the vertical banded gastroplasty. This was a cross-sectional study. When this is done more prospectively, these are data from Copenhagen, what you're going to see, unfortunately, in the form of a graph, is that energy expenditure certainly does not go up in humans. It appears to go down, and it appears to be proportionate to and appropriate for the amount of fat-free mass people have. So I think that at best, energy expenditure stays the same. More likely, it goes down. Now, I know that the rat and mice data contradict this finding, but that's why I'm trying to show you the human data, because I think they are more relevant. When it comes to the mediators of these changes, because I've talked to you about the overarching principles and their overarching methods. If we go into the principles or into the mediators that cause these changes, then things get very, very, very messy, because we have got differences between human studies and we have got differences between human and animal studies. And I wouldn't like to go into that in a lot of detail, but I will just summarize with some statements. First of all, with the gastric banding, we know that the mediators of the changes in food intake and body weight are not hormonal, are not related to bile acid signaling, and are probably not related to changes in someone's gut microbiota. It appears that all of the changes that we are seeing are neuronal and mediated through the vagus. In this human study, when there was optimal restriction in humans, you will see that satiety was higher compared to when you had reduced restriction of the band. And these are people who did not know at the time what was happening to the band. This is a single-blinded study. So this is evidence that the band does not cause restriction, but it causes changes in appetite and specifically an increase in satiety. If you do similar experiments in animal models, you're indeed going to see that there is certainly higher positive staining in the activated nuclei of the brainstem, which is where the vagus nerve terminates. And it is evidence that, at least in rodent models, the band works through these neuronal signaling pathways only. When it comes to the gastric bypass and the sleeve gastrectomy, the only thing I can tell you to avoid getting shot is that probably gut hormones play a role, and they don't play a role individually, they play a role together in combination. I can tell you that bile acids also probably play a role in the reduction in food intake. Difficult to prove in humans, and I can also tell you that microbiota also probably play a role. But if you try to dig into these specifics and the specific studies that try to identify the specific contribution of these mediators, you're going to find a lot of discrepancies. But I think it is reasonable to say that they do play a role in the processes that I have described. So to summarize, I will say that it appears that from the evidence so far, these operations, very similar to drugs, mainly work by making people eat less. We are not seeing major changes in food preferences, and we are not seeing any major changes in energy expenditure. There are major discrepancies between the human and animal studies, and this is a major problem, because if we do not understand what's causing these discrepancies, it is impossible to know which data to believe. And then you're going to ask me, what is the point of studying these mechanisms, the mechanisms of action of surgery, now that we have got all of these drugs available? Funders are increasingly replying like that to grants, saying, what's the point of studying the mechanisms of surgery? And the answer is, it is very important to study the mechanisms of surgery for many reasons. First of all, it is still the most effective treatment. If we understand the mechanisms through which surgery works, we're also going to understand the reasons why surgery doesn't work. And if we do that, then we will be able to use medications or other treatments to deal with the mechanisms that surgery has not been able to target. So this is all I had to say on this. Thank you very much for the invitation, and thank you very much to my collaborators in the field.
Thank you, Alex, and thanks for all the speakers. While the audience thinks on any question, I'd like to ask our two panelists, Francesco and Phil. Francesco, I have a question for you. How is still talking about restriction and malabsorption, how much that impacts negatively in our field? Because we see all the time that the bypass works with restriction and malabsorption, And drugs do not restrict and not malabsorb anything. Alex showed beautiful data. So what's the intensity of harming our field, keeping saying that?
Well, I think for many years this has been an easy explanation, an easy narrative for patients. If you have a patient coming to your clinic and you have to describe why they should consider surgery, what's going to happen afterwards, telling them they're going to have a smaller stomach, they're going to eat less as a consequence, they're absorbing less, it's straightforward. Everybody understands, including surgeons, which makes it obviously an important point. So that's straightforward. It's the simplicity of that argument is in fact the problem that we had in this field for so long. We are communicating two problems here. One is something that is not scientifically true, and so that's already a problem. At the same time, you are communicating a complication to somebody. You're telling to somebody restriction is something associated with not normal life. Malabsorption, by definition, is not normal. So you're telling people, I'm going to try to heal you, but I harm you. I think it's counterintuitive, and it makes actually people walk away from surgery more than coming forward. So I think we're making two mistakes. We are not communicating science, and we're definitely alienating people, and this should stop. If you want to do bariatric surgery, please do not tell people restrictive malabsorptive procedure. It doesn't help anybody.
Can I follow up this to probably to Phil perhaps? So most of the data we saw today is not new. In fact, some of the references are from a decade or two ago. So we have known for a long time that restriction and malabsorption are not a thing. But we still talk about it all the time. And I appreciate Francesco's comment that the need for it. But we now know that that's not true. How do we change that so that in an IFSO conference in future, the term restriction and malabsorption is just something that people remember from the old days?
Well, I have a little different take than my colleague Francesco. These terms are descriptive terms. Restriction can mean many different things. I think what Alex and Carol articulated is quite clear, is that these operations do not provide mechanical barriers to food intake, okay? And that's what I think surgeons used to think when they used the term restrictive, that it was a mechanical barrier. However, what Alex did show us, and this is to confuse the terminology a bit, these operations restrict calories. They do reduce calories, and some people use that term restricting calorie intake. So we have to be careful, about the terminology and how we use it. Secondly, and the words aren't bad, it's just how we use the word. We can't blame the word restrictive. It's not its fault. It's how we use the term. The other is malabsorption. Now, Alex didn't show you any data on, fat malabsorption for gastric bypass. There are some studies. It's not tremendous. There are 3 or 4 studies that look at fecal fat malabsorption before and after gastric bypass, and there is a modest reduction in fat absorption or increase in malabsorption after gastric bypass. Somewhere in the range is about 200 calories per day. Now, that's not a huge amount. That's about the amount of a Snickers bar, a candy bar, but over a period of time, that could have some relevance in terms of the body weight regulation. So I think we have to be careful about saying that these operations have no malabsorption. And for sure, the biliopancreatic diversion type procedures have a lot of fat malabsorption that probably plays a big role. So I think we have to be careful about completely saying we have the answers to all of these mechanisms. But I do agree that we should move on from the term restriction, because I think it is a bit confusing, and perhaps use terminology that is, reducing appetite or appetite reduction or appetite restricting or calorie restricting, as opposed to, a mechanical barrier, which we all know is not taking place.
But we can agree that restriction, physical restriction and malabsorption are not mechanisms of action of the operations. You do agree with this? Or you still think that malabsorption is a mechanism?
Okay, depends on which procedure. Obviously, with
The gastric bypass and the
bypass.
sleeve gastrectomy.
But with, no, what I'm saying is with gastric bypass, Ricardo, there is some data showing that there is some fecal fat malabsorption, is increased fecal fat, in the
But
stool
it's-
that you measure.
It's not clinically relevant for the outcomes long term.
Well, in terms of total body energy intake, you can either reduce the calories you're consuming, or you can reduce, and you can also reduce the absorption of calories, into the organism. And both of those may result in total reduction in energy intake. Follow me?
Carol, do you agree with that? With malabsorption?
Put you on the spot, Carl.
Yeah. Jump in.
So I agree with Phil that there's studies that show this increased fat in the feces in some patients. We also know that one of the main problems that we are having with the medications, but also with surgery, is that patients become constipated. Right? And the patients who do become constipated lose the same amount of weight that the patients that don't be constipated. And it's difficult to imagine being constipated and calorie malabsorbing at the same time. But so I think what we are seeing is that obesity is not one disease, and you do exactly the same operation and you see this perfect biological distribution, so of responders and non-responders. And I think not all the mechanisms need to be at play at all the time, and I think some of the types of obesity respond better than others. So in summary, I think that there is there's fecal fat that is increased on average. There's a large number of patients that have weight loss that don't have any increased fecal fat, but I think it may play a role in some patients. Is that a fair compromise, Ricardo?
Yeah.
So if 80% of people who take semaglutide has constipation, how come it works so well? How comes retatrutide? I don't know if they have obstipation or not, constipation or not, but I think it seems weird to me that 200 calories in some patients will do something regarding the outcomes long term. I'm sorry, Phil.
So never compromise, especially with Phil. So I would say the picture is much more complicated. When you think about energy intake, you assume that it's all the food you're eating is going in as energy. That's wrong. There's a lot of that energy that goes out. That's what the flash, right? And the reason is because there is a number of other factors that determine how much energy you extract from food. That is also biologically determined. And there are a number of factors, including ourselves, like our bugs in our gut, that contribute to that. So once we do these operations, we might reduce appetite, we might reduce actual food intake, but we don't actually know exactly how much energy in or less is coming. And in fact, we have one of my PhD students now is doing a study about measuring energy in the stools of mice. Of course, mice are not the same as humans. And guess what? Sleeve gastrectomy seems to induce a greater extraction of energy from food. So they're eating less, but they're absorbing more. At the end of the day, they're getting probably the same amount. So the picture is very complicated. And I think it's difficult to simplify. But all the more, if it's so complicated and we simplify too much, and we give patients a simplistic view, we're not doing a good service to them. So you're right. It's mechanical restriction that is the problem. But because it's not true, let's not give patients something that they could interpret differently.
Okay, but I think this issue of malabsorption has not been studied as well. I think we probably all can agree that it plays a role with the biliopancreatic diversion. In fact, those patients have steatorrhea. If you look at their stool floats. Why is that? Because there is very poor absorption, of fat, and it's actually much more significant. It's probably 400 or 500 calories a day, which is much more significant than with the gastric bypass. So, with the BPD, if you're bypassing 2/3 of the GI tract, and a gastric bypass, you're bypassing 10, 15%. Doesn't it make sense that there would be some relative?
What you're saying is true.
Yeah.
There is no question about this. The question is that relevant for the mechanism of surgery or for the mechanism of its complications? I would argue that the malabsorption is a mechanism of complications of BPD, but not as necessarily explains the efficacy of BPD altogether.
Alex has a question or comment.
comment that I think these discussions are very important, not necessarily because of the primary effects of surgery, because when the patient comes back to you with weight regain, right, it has got implications because you say, aha, why don't I make this stoma smaller so that I cause mechanical restriction, right? So there we have a problem in terms of direction of treatment. I know many of you will disagree and this will be controversial, but it's important to have some agreement on this, because then the direction of travel is wrong. If we say it causes malabsorption, then we will say, okay, let's make that limb longer and the other one shorter in order to cause more weight loss. We are really going down the wrong route. So it hasn't got implications just from the primary operation, it's got implications for the weight regains. So my suggestion is certainly for the weight regains, if we understand the way that surgery works, then we can say, okay, this didn't work very well, let's hit another target, but let's hit another target that we ought to treat, not the wrong target.
Very good point. So, any question from the floor? Please go to the microphone, introduce yourself. Please.
Professor Tess van der Merwe, South Africa. You cannot get away from the fact that the pendulum cannot swing that far. There is an element of malabsorption because we deal with patients in clinical practice that's got protein malnutrition, that has got malnutrition. You can call it whatever you want to, but if you sit in front of the patient, yes, the primary mechanism is control of satiety and producing the hunger. But whether we like it or not, we are still dealing with operations, depending on the type of operation that you have performed, that will give you a certain amount of, call it calorie wasting. If it's calorie wasting, it means that even if you eat your 2,500 calories a day, that is not what was available physically to the body. There's a big difference between what you eat and what is available to the body. And you only need to go and look at the blood test 12 months down the line to see what is happening. And I think one must also accept that there's individual variation and that there's also ethnic variation. Not all ethnic groups tolerate the same procedures in the same manners.
I couldn't agree more, and I think it's true that there are some patients, but as you say, there are some patients where malabsorption may be more important than others in terms of consequences of surgery because of many other factors than their gut and what happens, etc. But I would use that as an explanation for complications of surgery, to explain to somebody why you're having malnutrition, whereas majority of patients don't. But I wouldn't use that argument for weight to explain to them why they're going to lose weight, because I'm not sure that we have the evidence that that's the reason why they lose weight.
Yeah. Now, and
One more question, sorry.
Okay.
We can. Audience
Hello, I'm Dr. Jenny Nasi from Montevideo, Uruguay. I want to congratulate for this wonderful panel. We have learned a lot. This is a scientific discussion that we need to have. But the main thing with the patient is the first time we see the patient that may be a candidate for bariatric surgery. I spend 1 hour to explain him or her what I'm going to do. I make my drawings so to make her understand what will be going on during surgery. So I have to use terms that the patients can understand. And let me tell you, they understand very well when I say restriction or when I say disabsorption. I never use the term malabsorption because if it's a benefit for the patient, it's not bad. So I thank you for this scientific discussion. But remember that our job is for the patient, and we need to explain very well the patient. Entonces, let's not do a semantic discussion. It's the same that don't use any more body mass index because it's not correct. but the patients understand very well, and they know very well what that it means. So I still use body mass index. I still use restrictive in terms of mechanism of restriction, and I still use terms of disabsorption because my patient will understand very well what I'm telling about. Thank you very much.
Thank you. Thank you for your comment. I'll take that if that's okay. And I'll say that patients understand what we explain to them. And also patients will listen to the surgeon, of course. And if we're convinced about something, they'll hear that. But if you look at the data that Alex Mira showed earlier on, our patients are eating exactly the same as controls down the line. And they will know that. They will know that a year or two down the line. So talking about signaling or appetite or satiety, which is what I do in my clinical practice, is as simple, if not simpler, but definitely more accurate than talking about restriction, mechanical restriction and disabsorption, hypoabsorption.
I also use hunger and satiety too. Thank you.
One more question from
No,
last question.
Santoro from Brazil. Indeed, I would like to agree, but more than agree. Malabsorption, it doesn't help at all. Because now it has been shown that it's the absorption of nutrients that provide gut hormone secretions. So, and it has been shown already that when you compare a SADI procedure with a duodenal switch, one, there is more malabsorption and the other has less because of the longer common channel, but the secretion of the gut hormones are better where the ileum is exposed to bile and it's absorbing better. So malabsorption is still a disease, yes, it is a disease, and it's not helping. It's exactly the opposite. It's the ileal absorption that is what we want. So it's distal absorption instead of malabsorption. And I think that this is an important concept. And one more thing about the restriction. We wrote an article in Annals of Surgery in 2015 making a distinction between what is mechanical restriction and functional restriction. Functional restriction is exactly what you were mentioning. It's a restriction that is self-imposed because you want less. So I think that using this terminology, mechanical restriction versus functional restriction, is an important thing because the last one is self-imposed.
Thank you. Sorry, we need to close. I takes only a few minutes for a final general question to the speaker. So you completely explained to us that obesity is a disease characterized by a dysfunction of the regulatory mechanism. So the core business of obesity is an alteration of our set point for body fat. I agree completely with you. How we can incorporate this question in the diagnosis of obesity? Because until now, we are diagnosing obesity using body mass index, the content of body fat. We are not using the pathophysiological basis that you explained to us for the diagnosis of obesity. How we can incorporate this new thinking in the diagnosis? Lee.
It's late, so I'm going to give a very short answer.
Thank you.
I think the way we do it in the long term is we understand how the body regulates its set point. It's part of the brain, as Carl was saying. We don't understand it. We will understand it over the next 20 years, but that's for later. For right now, the body gives us a clue. That argument that we just heard, or discussion, or whatever it was, that we just heard from my colleagues and friends about whether malabsorption is or disabsorption is a good thing or a bad thing, is based on what is disabsorption or malabsorption doing when it happens to occur after one of these operations, is that it does occur after many of these operations. But what is different about this malabsorption or disabsorption compared to, say, if you just cut out the bowel for uncontrolled Crohn's disease, is that the patient is less hungry after bariatric surgery despite the lowered absorption. And after, in Crohn's disease, when you cut out the bowel, I'm speaking as a gastroenterologist, you get hungrier. And that's been demonstrated in numerous studies. However, yeah, you're raising a question probably that has to do with ketosis, but we're not going to talk about ketosis. So the reason I say all this is because the way we can use what you just described is that the first thing that happens with these medications and with surgery is that the patient says, I'm not as hungry, and the patients say, food doesn't control my life anymore. They particularly say that with the medications because after surgery, they're busy worrying about the post-operative care. But with the medications, they just take a medication, they say, food does not control my life anymore. That becomes the first clinical symptom of effective therapy. So as you say, how do we use the symptoms? How do we use this information? We use information because the patient who doesn't feel that way, it hasn't been studied, but it needs to be, is probably going to lose less weight. The person who doesn't get that food doesn't control my life anymore feeling is probably the one who's least likely to get a major effect from the therapy, whether it be surgery or not. Remember, all of these new drugs and surgery always cause weight loss, but there's a big difference between 40% weight loss and 10% weight loss.
Thank you very much for all the brilliant presentations, and thank you to the audience to be with us this afternoon.